Welcome to the Physician Associate Podcast.
Hello and welcome to this episode of the Physician Associate Podcast. My name is James. Today I'm delighted to be joined by Jovy Giles, who is a Physician Associate working in palliative medicine. Welcome to the show, Jovy.
Hello, thank you, James.
Do you want to start by introducing yourself? Tell us about you and your life before you were a Physician Associate.
Sure. Before I was a PA, I studied biomedical science for 3 years in Kingston University, which I really enjoyed doing, like volunteering at the local hospital. And actually, I was volunteering on dementia wards. So I spent a bit of time looking after, obviously, elderly patients and patients with a little bit of specialist care need, really. And then from that, I decided to work as a healthcare assistant for a few months at the Royal Hospital for Neurodisability in Putney, which is a charity-based hospital, a charity-funded hospital with only a very small fraction of NHS funding, providing specialist care and support to people with lifelong neurodisability. So that was a really lovely job, actually. And that did ground me and made me realise that I really wanted to do a job that was very humbling, but also something that I felt was really meaningful and could offer genuine benefit to people. And I thought I wanted to do medicine, but I wasn't sure that I would get along very well with how medicine is structured in terms of, I do a little bit better when things are less regimented, and I enjoy like flexibility and having a bit of fluidity to my job. So I wasn't sure completely that it was for me. But I went with one of the, I met this person at the interview for the healthcare assistant job at the RHN, who was also interested in medicine. We went to a conference together. I think it was Medicine's Updates in Medicine conference or something back in 2015. And there they had a pitch about this new role, which was a medical job, but not being a doctor, and it happened to be a physician associate role. And I found it really interesting because it sounded quite good for me, a little bit more flexibility. You still get to maintain some level of your social life, but working in medicine and being able to provide something that I felt was meaningful and important to people. So I graduated in February 2018, I believe.
Went through your PA school.
Mm-hmm.
Intense, I'm sure.
Mm.
Came out the other end, nationals. What was your first job? How did you go about choosing jobs and what attracted you?
I decided that I wanted to do something more general quite quickly because I felt that it was really important to solidify the generalist learning that we'd done given our role. And I actually applied to work in Kingston Hospital on a care of the elderly ward. And I had a little bit of connection with the hospital already. I'd done my volunteering there. And fortunately, they hired me. And I worked there for nearly 3 years. It was really nice, actually. Except it was part of what made me realise that I wanted to do palliative medicine. So I was working on a care of the elderly ward for probably about eight months. But then one day I came into work and the consultant said to me, let's talk about your future. And of course, I panicked and thought, oh my God, what have I done? He said to me, have you thought about stroke medicine? And I said, well, I haven't, but now it's something I'd be open to because I'd done the job at the Hospital for Neurodisability. I'd worked with a lot of patients who'd suffered really severe strokes. So it was an extra opportunity for learning. And he said, we'd like to move you onto the stroke ward. So I asked when, and he said tomorrow. And I said, that's a bit quick. Can I have some time to think about it, please? And he kind of leaned back and said, sure, but don't take 5 months about it. So I thought, great, I'll take 4 months and 29 days. Because I really had built up such good working relationships with my team. And the other staff on all the nurses were great. And anyway, I went for lunch, came back from lunch, and he said, oh, by the way, you've been rotated into the stroke ward since this morning. Please, can you go there now? I felt I couldn't say no. I was in a very difficult position.
Yep.
when
Okay.
you're not asked and you're told and you're new. I wasn't even my first year in work. Although I was good at the job at the time, I was still learning. So I felt that, they're in a really senior position. Anyway, that's that. So later I went up to the stroke ward, and when I got there, I was greeted, well, not really greeted actually, but the first person I saw, so you walk into the ward and the doctor's desk was right at the front of the ward where you'd expect the reception to be. And I walked up to the desk and I said, "Oh, hello." And this lady, she looked up from her work at me and said, "I'm sorry, who are you?" And I said, "Oh, my name's Jovy. I'm the physician associate coming to the ward." About 5 or 6, I finally met the consultant, who was quite abrupt, but a little bit, I also thought, stressed out, and just said, "Hello, welcome." And that was the end of that. Very short, very sweet, nothing too fluffy. And I think we stayed until maybe like 7 or 8 o'clock that night working, because the workload was very demanding. And I think they'd been really stretched throughout the day. Anyway, the next day I came in, I thought, you know what, let's just see how it goes. Still trying to be open-minded. And if you can imagine being admitted with a stroke, I mean, it's either you could be now severely disabled for the rest of your life, or, okay, fine, maybe it happens and you do get a bit better, but it's still a huge adjustment to your life and rehab that you have to do. And I felt that the discussions that were had that were important to patients and families could be done with more tact, or could be done with a little bit more sensitivity, but honest, always honest. And I thought to myself, I could probably do a bit better than that. So I did start taking on like the DNA CPR discussions, and I started doing more of the, what would probably be deemed like soft skills back in their day, which we now just call communication skills.
Which we know are incredibly important.
Yeah, absolutely. And I got so much back from the patients and their families. I had emails and just written notes saying, "Thank you so much for being so honest with me. We really appreciate it. We actually feel we can move forward now." And it's really important and integral to an individual who's had something so significant happen in their life to be able to feel supported, because we know that those emotions do impact your ability to recover and your ability to, overcome difficult circumstances. So actually, that was where the palliative care team, who would come onto the ward, who would support some of our patients, decided to start liaising with me, because they knew that I would listen to them and take them seriously. And in a way, it made me feel more fulfilled at work. And those were the things that I really enjoyed doing. I did enjoy the stroke medicine as well, but being able to give people that emotional space just to feel safe was so valuable to me. And then I decided that I would try and ask for a secondment with the palliative care team. Unfortunately, that didn't get approved. And then COVID happened. I was really looking forward to going onto the mega rota that had been arranged for the junior doctors and the physician associates all to be in huge teams and rotate, because obviously we didn't have any real support back then. No one knew what was going on. Everyone was just banding together, and it was great. And I was so looking forward to getting a break from the ward for a little bit, to work with a different team. And then both the consultant and the registrar got COVID at the same time. And that was before PCR testing, so they were just off for 2 weeks. So for 2 weeks, I was the only stroke trained person in the hospital. The hospital had decided that they would cover the stroke ward with neurologists, because they obviously thought stroke brain, let's make it work. And the neurologist was so great. They came over and they basically were supporting me, and they said, "Look, we don't know what we're doing. We'll just take your lead on it." And towards the end of that 2 weeks, I felt so supported. They were so complimentary of me, saying like, "Oh, are you the registrar?" I said, "No, I'm just a physician associate. I'll do the MRI and the ultrasound ordering, but I can't do the chest x-rays." And they were like, "No, that's fine. We'll sort all of that out." And they really did make me feel like a colleague. And I actually remembered what it was like to feel valued at work. And I was so annoyed with myself for letting it get so far, because I just don't like, no one likes being taken advantage of or being made to feel undervalued or anything like that. So I spoke to there was a geriatrician covering the very end of those 2 weeks, and I hadn't worked with her, but she knew me because we were part of a similar team on my previous ward. She was the consultant on a different ward, and I just cried and cried and told her I can't stay here. I really need to go. I really need to leave. It's affecting my mental health. It's affecting my ability to do my job properly. And I really do think I am good at my job. And I realized I was. And eventually, after a little bit of time, I moved back onto my care of the elderly ward that I was previously moved off of. And although the work was extremely difficult and the patients are hard to look after, there's such variety, and it was busier. I had a much nicer team and I felt so much better supported. But by that point, I think it might have been in like June or July of 2020, I just thought, right, I need to look for a new job. So I started looking. I was already looking for a long time before that, but I had properly started looking for a new job. And I was looking for palliative medicine jobs. And there were just none, absolutely none for physician associates. I couldn't find a single one. And I'd looked for many, many months. I even had the alerts on that you could set up for specific like keywords. Nothing. For at least, I mean, it might have been almost a year actually. And I saw a clinical nurse specialist job at St. Raphael's Hospice advertised. And I looked at the job description and I thought, gosh, that would be so, so lovely for me. But I'm not a nurse. And then I thought to myself, what's the worst that can happen? I'll send in a CV and they say no. And I'll be here anyway. And I'll just wait until the job comes up that I want to do, because I wanted the next one to actually be for me rather than chosen for me. By that point, because I'd had a good relationship with the palliative care consultant, she'd actually recommended that I do the European certificate in palliative medicine. And I had done that already. So I already had a little bit of something to offer to a palliative role with a little bit of an enhanced baseline knowledge. And luckily, the hospice looked at my CV and liked it, and then they invited me for interview, and then they liked me and decided to hire me, which I'm very, very grateful for, because they are also a majority charity funded organization, and they've never had a physician associate work with them before, so it was a significant decision for them to take on my role, and I think we're both, me and the organization, very glad that they did.
That's nice to hear.
Yeah, now that I'm here, it turns out after I was working for a little while that it actually turned out that I was the first physician associate in a hospice in the UK.
What do you do as a physician associate in palliative medicine? What does your day look like?
So in palliative medicine in a hospice, it is different than in a hospital, I'm sure, but we are we're a specialist unit for palliative medicine. So normally day to day, we'll do handover, ward rounds, admitting patients. We'll just check through the drug charts, making sure any of them need rewriting. So what I'm doing at the moment, which is kind of new to my job, is going out to the community on a Friday morning and doing visits for people in their houses, and sometimes doing a first admission or a first assessment, they call it, a first assessment for patients at home, just to give them some exposure to the hospice. They'll have been referred to us beforehand. And yeah, it's kind of like general ward work, but we are a lot more restricted in the investigations and interventions that we can do here. So you have to have a very good clinical acumen, and you have to really consider whether the decision that you're making to either treat or investigate is truly in the patient's best interest. So there's quite a lot of considered measures that go into what we do, even though it can look very simple actually if you aren't in it. A lot of the time I'll be doing things like bloods if necessary, or catheterization. Quite a big part of the job is having meetings with families and discussing, openly what we think is happening with our patients. And we are a lot more holistic in terms of the care and support that we give to patients and their families. So we consider a lot of things other than just physical symptoms. We consider emotional, psychological, cultural, spiritual, general well-being, family support, carer support and needs at home as well. And all of those things can factor into an individual's journey, really. And trying to support people through what could be literally the most difficult point in their life, or coming towards the end of it, and being able to give them that space, that psychological safety to be able to express exactly how they feel, without judgment. Sometimes that is enough for people to actually start to feel better, because it is important to acknowledge that there's more than just your illness and then your physical condition. So I guess that is most of what I do. I do a lot of educational support as well at the hospice too, like teaching sessions for the nurses, teachings for the junior doctors when they rotate, and we host a lot of medical students as well. And I think most people's perception of a hospice is that they think if a hospice actually looked like what people imagine a hospice to be, it would look like a dungeon with chains on the walls, like mold dripping everywhere, dank, wet floors, because people think it's going to be horrible. People think it's like the inside of a tombstone when you come in here. But actually, everyone who's come is like, wow, this place is so beautiful. It's so calm. There's so much nature that you can just open the patio doors and patients can go out there. And we do allow our patients to smoke some of the time if they're able to get up and out, and be safely supported. Because actually, if that's something that brings quality to their life, however long it is they've got left, who are we to stop them? And people actually, the staff are very, very supportive. I think because people accept that this job has an emotional burden to it, the staff are often hyper aware of that and very, very supportive of each other. And that would be probably what I'd consider one of the most difficult parts of the job, is the emotional strain. But actually, because you're so well supported here, it doesn't even take away from the job. Actually, it just becomes part of it, and you just accept that life isn't always straightforward and it isn't always positive. I mean, in hospital, you have this huge emotional stress, but you just don't even acknowledge it most of the time. So to be somewhere where you're so supported and so heard and so considered, even just as a staff member, I mean, it makes us better clinicians for our patients.
Being a physician associate currently means we're an unregulated profession, but we know that the GMC are going to take over regulation of physician associates in 2024. But it does place some restrictions on what we can do at the moment in terms of not being able to order ionizing radiation, and we aren't prescribers either. Does that have an impact in your job day to day as a physician associate in palliative medicine?
In a hospice specifically, my hospice specifically, because actually all hospices are slightly different in what they can provide, because they're not usually fully NHS funded. They're mostly charity funded with some NHS support, thankfully. And palliative medicine has only just been acknowledged as a core speciality by the government's eyes as of March 2022. So it's a very fresh, new and emerging speciality, really, compared to a lot of others which have quite significant history behind them. But in my hospice specifically, we don't have access to scans, so we can't request any scans. So that doesn't limit me at all, actually. If somebody does need a scan and therefore hospital transfer, we will send them to an acute hospital to have those scans done and to have further investigations. And in terms of prescribing, it does limit me, of course, as it limits every other physician associate, because there are a lot of things that I feel I am capable of prescribing and managing, but cannot due to legal reasons. But fortunately for me, I have got a very supportive team who really respect what I do and trust what I do. And I'll be able to review patients, make management plans, and discuss them with the consultants or the other doctors, and they'll be able to prescribe on my behalf. But if I was able to prescribe, it would add to my job value rather than detract.
Is it fair to say with palliative medicine, and forgive me because this might be my total misunderstanding, because I work at the other end, I work on the acute admissions bit of the system. A lot of it is prescribed ahead of time just in case, isn't it? So you don't necessarily need an acute prescription there and then, it's already in hand.
So we do prescribe anticipatory medications in case someone is approaching the end of their life. But I think what people often don't realise about hospice is that actually the majority of the patients we admit, we discharge home or to a nursing home for their next best place of supportive care. And obviously those people don't always need anticipatory medications. They will need their regular prescriptions, or we'll be doing a symptom management admission where we need to try other things that they haven't already tried. And because we're a hospice and a specialist service, we can be a little bit more confident in terms of what kind of treatments that we can try, because some of them would not be safe to start in a community setting in someone's house, for example, but on a hospice ward there's nurses around 24/7, so we can try things because we're very aware that we do look after a particularly vulnerable group of patients whose risk of deterioration from a terminal illness and the burden of other comorbidities, potentially their risk of deterioration rapidly is quite high, but you can't predict with any certainty what might happen to somebody, although you can assess prognosis, and we are pretty good at assessing prognosis, really. I'd say better than in hospital, but people always look more sick in hospital, I think. And then when they come to a hospice and they have excellent nursing care and other things supporting them, people tend to get better, actually, and then they go home. Having the prescribing rights to be able to do other things to support people would be great. And if it was something that they would rather have treated in the hospice than in hospital, then of course we'll do that as well.
Fab. What are the benefits of having a physician associate in a team for palliative medicine?
Why would you want a physician associate to support your team? Well, why wouldn't you, really? Because we're still generalist medical professionals in terms of being able to support the diagnosis and management of diseases acutely. We've got enough breadth, I suppose, hopefully, to be able to manage the wide scope of patients that we look after. Palliative medicine really is just an extension of general medicine. So being able to have that generalist knowledge is very handy, especially if you're needing more consistent people on your team, because we're a consistent medical professional that can be there to support the ward or your community team generally. And with the new dual accreditation of palliative registrars, our particular hospice, I don't know how this will apply to others, but I feel that because the training is slightly changing now and the registrars are expected to do a certain proportion of time in acute hospitals as well as in hospices, there is going to be a reduction in the amount of time that the registrars will be available. And having somebody who is a consistent permanent member of your medical team, one, will be really helpful in terms of managing patients and generalized rapport with the staff, but two, we can get to know the intricate systems of the specific places that we're working. And given that all hospices can vary, it's always handy to have somebody who really understands how the referrals work, how the kind of general culture on how things would be managed in your specific hospice would be really handy for that. I can't comment on hospital palliative medicine, but in hospices, I think that my team have found me to be a huge asset to them.
I'm sure you are.
I would say that in terms of palliative care, which I would consider being more like generalist basic principles, every physician associate should be capable of providing those general basic principles of palliative care. But if you feel that you have got more to offer and you'd like to learn about a specialty that is actually quite cerebral, even though it's difficult to see that sometimes from the outside, everything we do is very considered. And I have never, even in medicine, worked in a different area that has felt so human and so supportive of the things that are genuinely important to people. We get to look after people in the way that they really want to be looked after, and we can provide care that is truly individualized. I would say, don't knock it till you've tried it. And actually, a lot of people worry about looking after someone who's dying, but actually, I feel that looking after someone who is coming towards the end of their life is something that should be really important and valuable and precious, because it's so nice to be able to talk to somebody who is coming towards the end of their life and says something to you like, thank you so much for everything that you're doing for me. If I knew this was how I was going to die, I wouldn't have been so frightened. I wouldn't have been so scared. And I would have been able to talk more honestly with my family sooner, things like that. And it's just something that is a bit difficult culturally, I suppose, in England, really. But generally, death isn't the worst thing that can happen to somebody. But just to reiterate, we don't always just look after people who are dying. But if people do deteriorate with us, then we'll make sure that the care and support that they have at the end of their life is genuinely the best that they can have.
Yeah, lovely sentiment. Where should people go to find out more information about physician associates in particular and palliative medicine as a whole? If there's a PA or a PA student thinking about going into it as a career choice, where would you point?
Yeah, do you know, I actually just had a few people email me and were like, can we come to your hospice? This person wasn't a student, so that's very difficult because a lot of people are looking for like work experience. And the thing with work experience is you need to have somewhere that can really be able to support that. And hospitals generally are a bit better than hospices because they're usually smaller environments. But if you're a student or somebody who's working in a different specialty but's really keen, then you could always just ask to do like a small placement if that's feasible to your team, because we have a lot of GPs who come just for a short time, or IMT trainees who just come for a week or just even a few days. Sometimes we get F1s and F2s who just want a little bit more of an idea of what hospice is like, because it's so underrepresented in your training that actually most people's perception of what it is completely false. And the other thing that I would say is because they're usually charities, you could always volunteer and get a bit more experience that way. And they're more than happy to have you, even just like once a month or once every few, if you can't do sooner than that. Any help is good help. But that way you'd be able to understand what it is that your specific local hospice, if that's what you're interested in, would be able to offer, and potentially go in from that direction, because then you would know that you might be able to know the team a bit better. But just ask. They're generally happy to have us.
They're always really nice, lovely people, aren't they? They're always. And you mentioned a European qualification that you'd done in palliative medicine.
Yeah. I think it's called the European Certificate of Palliative Medicine or Palliative Care. It's a certificate that is paid for. It's an 8-week course, if I remember correctly, and you'll get sent like a pack. You have to look through it, learn about it, and then you have to sit an exam. It's quite a quick exam, and there's usually a communication OSCE attached to it, but it is a very good qualification to have if you are even considering palliative medicine. You don't have to be a medic to do it. Nurses can do it. Healthcare assistants can do it. Actually, I think it's open to almost any staff member, as long as they have a clinical job and some interest in supporting palliative patients or patients who've got terminal illnesses. So that is definitely one to consider. And if you're lucky, you might be able to get your department to fund you on it, because you could argue it's an extension of general medicine. I would do that.
Brilliant. Thank you, Jovy.
You're very welcome. Lovely to chat with you, James.
And thanks to you for listening as well. I hope you found that a really useful episode to find out a bit more about physician associates working in palliative medicine. If you're a PA working in a really cool specialty and would like to come on the podcast, it would be great to hear from you and to find out what you're doing. So please get in touch. I'm on social media at PA Podcast UK, and I hope you'll join me again for the next episode.
Thanks for listening to the Physician Associate Podcast.